today's webinar. It's a co-hosted webinar today called Going All In to Improve Health Through Multi-Sector Collaboration and Systematic Data Sharing, brought to you by County Health Rankings and Roadmaps, the All In Network, and Data Across Sectors for Health, or DASH. So the County Health Rankings and Roadmaps program is based at the University of Wisconsin Population Health Institute and is a collaboration with the Robert Wood Johnson Foundation. My name is Justin Rivas, and I'm a community coach at County Health Rankings and Roadmaps, and I'm joined today by a superb team of presenters. Everyone's going to kind of say hi as I introduce them. Let me welcome Peter Eckert, who's the director at DASH.
Howdy, everybody.
Howdy, Peter. Elise Citrini, who's a project supervisory attorney at the Legal Aid Foundation of Chicago.
Hi, everyone. Thanks for having me.
And Martha Davidson, Senior Director of Development at Trenton Health Team.
Hello, everyone. It's great to be here.
Thanks, Martha. Great to have you. Just so attendees know, we have multiple people supporting us behind the scenes on today's webinar, including Anna Barnes, Karen Odegaard, Raquel Bornesk, and James Lloyd. So if you see those names popping up in chats or questions, and I know you didn't memorize all those names, but just a heads up that we have some other folks helping us out. So if you joined us a few minutes early, you saw a video introduction. For those who are just joining, we'll do a quick overview of how you can participate in today's webinar. If you have a question for our panelists, simply click on the Q&A control. When you do, the Q&A box will open up. Just type in your question here, hit click then, and you can submit your question and send your answers at any time. If you want to share an idea with all the attendees, you can use the chat function to make some comments or respond to questions that we pose to you during today's webinar. To use the chat feature, just click on the chat control, type in your comments there, and then hit send or submit. And in the chat function, it's important to know that you have the option to either share to all attendees, and if you can do that and if you're willing to share your comments with everyone, that'd be really great. So we have a full plate today, folks. Here are kind of learning outcomes for the day. We hope to understand County Health Rankings and Roadmaps approach, data, tools, and resources, have an understanding of the All-In and DASH approach and their tools and resources. More importantly, really get an overview of the value of multi-sector data sharing, or the theme of today's webinar, gain some insight on how to start and maybe how to deepen this work if you're already doing it. And importantly, learn from the Trenton, New Jersey team and the Chicago team on examples of best practices for data sharing across sectors. So let's frame this in a couple of guiding questions today. Today's webinar is really geared more towards those communities that are just dipping their toes in this work, communities that are maybe newer to it or in the earlier stages. And I think we can think of the content for today at a few different levels. And I think this image captures both. It depicts the concept of collaborating or integrating or maybe even weaving, if you will. One level could be framed locally, or thinking through data and systems integration in your own community. But there's also a broader level that could be thought of in also weaving organizations, networks, and communities as peer learners across the country. Thus, let's kind of frame this in the two questions of how can your community pursue or build upon your data sharing work? And how can you benefit and also provide benefit to others by being part of a nationwide learning collaborative around this work? And we'll have an opportunity for more shared learning following this webinar with a discussion group that's coming up next week to get some more deeply into some peer learning, and I'll have more details on that in just a bit. So now that we have a grounding in a specific direction for our webinar today, let me back up with some framing of the County Health Ranking and Roadmaps program. Let's start with the why. Why do County Health Rankings and Roadmaps exist? Why do we produce the tools and resources that we do to support communities? County Health Rankings and Roadmaps has really two primary overarching goals. The first is to improve health outcomes for all, and this includes both how long people live and how healthy they are, or length of life and quality of life. And our second goal is to close the health gaps between those with the most and least opportunities for good health. We believe that everyone should have a fair opportunity to be as healthy as possible, regardless of where we live or the circumstances we're born into, and that the choices we make depend on the opportunities we have. Things like access to healthy foods or quality education or living in safe and affordable housing and crime-free neighborhoods. And not everyone has these same opportunities. These unequal opportunities create differences in health, and they do not come about on their own or because of the actions of individuals alone. They're often the result of policies and practices at various levels that have created deep-rooted barriers to good health for some people, which means that everyone does not have a fair and just opportunity to live a long and healthy life. But communities have the power to change this. Think about your own community. Think about who isn't thriving, who doesn't have the same opportunities for health, what barriers maybe have been put in place over the years, and what it'll take to remove these barriers and change the opportunities in your own community. Now maybe think, what opportunities do you see in your own community for closing these gaps in health by possibly effectively sharing data and integrating to close those gaps? So if you could think of maybe some ideas around equity issues in your own community and maybe how data sharing could help improve those issues, I'd like you guys to maybe chat in some ideas and we could maybe share back with the group later and also kind of collect some thoughts about things going on with guests from around the country. So we at County Health Rankings and Roadmaps work to support communities to bring people together to look at the many factors that influence health, to select strategies that can improve health for all and close gaps, and to make changes that will have a lasting impact. We do this by providing data, evidence, and guidance for communities. We also work together and share the stories of communities from around the country, which we're doing today, that may be at different points on this journey to serve as examples and inspiration for all of us and all of our partners. So we just talked about the why. Now we'll look at the what and the how a bit, if you will. And as I mentioned, one of our goals is to improve health outcomes. So let's look more closely at this. The image you see here is our rankings model. This helps us understand the what of what drives health in a community. One of the goals we've had with this image is to help change the conversation about health and what influences health. What this image shows us is that health is more than what happens at the doctor's office. In fact, a wide range of factors influence how long and how well we live. It includes things we often think about when we hear the word health, like health care, or how well we eat, or how much exercise we get. But we know it also includes things like education and income and the quality of our housing and the safety of our neighborhoods. So now I'm going to offer an opportunity for the attendees to get involved a bit in today's webinar. And I'll have James launch a poll. And this poll is going to kind of gauge your familiarity with our model or your experience in using it. So a poll should be popping up on your screens. And go ahead and just click the answer that applies best to you. And you guys are rock stars at attendee engagement. We are already halfway through. So I'll give you guys a few more seconds. And we're almost at 3/4 of you. And what I'm seeing initially, wow, is really a mixed bag. It looks like about half of you have seen it or maybe looked at the measures. About a fifth of you have used it quite extensively, and about 30% of you are on the lower end of not being engaged. So that's awesome. That's great that we have a mixed bag. So we're gonna end polling, and I can actually share those final results with you guys, and we will keep going. Thanks, James, for launching that poll. Now let's think about the how of moving data to action by reviewing our theory of change at County Health Rankings. This picture shows us the thinking behind how population-based data can be a catalyst for action that improves health and increases equity. Let's walk through this. We start with population-based data from a variety of sources. Then we use the data to rank the health of nearly every county in every state. Ranks are great for garnering attention, and each year the rankings generate national, regional, and local media attention. Data also provides an opportunity for people to tell the story of the many factors affecting health in their community, what's going well, and where there's an opportunity to make things better. And when thinking about what things to improve, community members can start to identify evidence-informed strategies that can be implemented to make change. And over time, these strategies ultimately result in longer, higher quality lives for everyone in the community. And ultimately, the rankings aren't just about the numbers, they're also a call to action. So you can use the themes in the data to either start or continue a conversation about health, or maybe even to articulate a need for data sharing across sectors in your own community. So our data is a resource that can be used throughout the community health improvement process, and we have seen communities use it in many ways. First, it can be used to assess the health of a community. Data can also be a tool for engaging communities in health improvement. The County Health Rankings model became a tool to talk about social determinants of health and how to respond and highlight specific measures that can help create a sense of urgency around certain issues. And data can also be used to identify the root causes of health issues. For example, we may think healthcare access is the problem, but it could be access to transportation to healthcare. It can also support decision-making and policy change, and data can be used ultimately to track progress as well. So let me shift now to data to action, and we'll show you where some of these resources live for taking action. This is a screenshot of the Action Center. It's labeled as Take Action to Improve Health on the top scroll bar of our website, and you can click on that to find what we're going to talk about next, which is the Action Center and the Partner Center. So the Action Center provides step-by-step guidance and tools to help you move with data to action, and each action step is broken down into key activities with guidance and suggested tools to support your work. I like to think of the Action Center as a destination, and when you get there, you can take a look at the steps that really are involved in moving community health forward. Some tools and resources that would be most useful in relation to today's webinar are concerning multi-sector collaboration, could be found in this working together or work together area. And we're going to dive into one of those tools next really quickly. In the work together step under key activity 3 or manage boundaries, we have some tools for boundary spanning that come from the Center for Creative Leadership. And they can support with kind of the theory on process and help you answer questions around collaboration, like what are barriers to collaborating? For example, boundaries can exist between groups, regions, different sectors in your community, stakeholders, and or cultures. And these boundaries might be around things like trust or lack of relationships. And they could be thought of as vertical boundaries, horizontal boundaries, stakeholder boundaries, maybe geographic boundaries. These tools can help you think about the leadership that's needed to overcome these boundaries. And the framing is in this idea of direction, alignment, and commitment. And the commitment can be around a shared goal or mission. Maybe that's a data sharing agreement that you're trying to realize in your community. Boundary spanning leadership is also a tool for moving across these boundaries. So here's some kind of strategies to think about bridging and connecting across boundaries. And this would be in that kind of third image you see there. You could first manage the boundary, so clearly see, define, and understand the differences and uniqueness between the organizations and services, different organizations, their data, how it's gathered and collected. You could next forge common ground, find what is universal and connects you on the larger issues. That could be, for example, maybe children's health, or maybe you're working on eliminating homelessness, and then discover new frontiers. You could think about how to innovate and find opportunity in the space of what makes you different, but also where you can integrate your best practices. This could be around how to best share data. And lastly, I want to highlight our Partner Center because we know that everyone has a role to play in creating healthier communities. And this is really the who, or the who should we work with in community. You could think about the people in your community who make positive change happen. We call them leaders, change makers, or stakeholders. And this helps you find out how to reach them. Right. The Partner Center offers background on lots of different sectors, as you can see. And to think more about partnering, I'm going to now pass it on to Peter, who will take forward from here.
Thanks, Justin. Hi, everybody. Thrilled to be partnering with County Health Rankings and Roadmaps on this webinar, and equally thrilled that there's almost 400 of you participating today. So I want to be somewhat brief and get to the communities that we've invited to participate. But I also want to recognize that for a lot of you, this kind of thing is relatively new. And why wouldn't it be? Data sharing is super hard, especially when you're talking about doing it outside of your organization. It's slow and it's expensive and it's complicated. It's complicated politically and technically. And so for a lot of folks, they try to stay away from it. But for folks who've got a bigger vision, who recognize that there are some things that you just can't do for yourself, but you've got to share that work with others, collaborative work and data sharing work is really the way to go. And we're also noticing right now with so many people interested in health equity, they're recognizing that multi-sector approaches and the data sharing that comes with it can be a way to accelerate and operationalize this work in health equity. Next slide, please. So I'm going to talk today about all-in data for community health. But in order to do that, I want to talk about sort of some of the things that we're interested in. And we really restrict ourselves to three important components of work. The first of which is working in collaboration. The second of which is taking a multi-sector approach. And the third of which is doing actually systematic data and information sharing. Our purpose is, in all of this work, is to increase the capacity of community-based organizations and their partners to participate and drive community health improvement. And so that really looks like a lot of different things depending on what community you're in. Next slide. We've got a really cool video that we won't show today, but I've got this slide up on the screen right now because I want to say that all of the approaches that our communities take are really rooted in a specific community. These are not sort of generic approaches. They all are rooted in a community response to a specific problem or a specific opportunity. And so we'll talk a little bit about who gets involved in this, but you know, just like so many of you in your communities, you're starting to gather people around the table and saying, how can we work together and what kind of data do we need to make that work? Next slide, please. So to give you an idea, just a real quick overview of a couple of the kind of projects that we support, I want to talk about sort of two broad categories of work. And so one of them was described pretty well by Justin earlier when he talked about the kind of work that shows up in county health rankings. And that's what we think of as population health approaches. This is stuff that typically is addressed by policy, systems, and environmental change. And these are projects where folks from different parts of the community get together and they share aggregated data, they share grouped data, they share data that describes the whole community. And so one example of this is a project that DASH has supported in Baltimore, Maryland, their Befriend project. And it's something led by the local, by the Baltimore Health Department. And they've got this fairly audacious goal to reduce the falls among elderly people in their community by 1/3 over 3 years. And so to do that, they are leveraging not only data that they have in place at the health department, but they're also using information from their local health information exchange, which I know that many of you understand as the way to aggregate a lot of information from different healthcare organizations, hospitals, health systems, doctors' offices. And so they're taking a very holistic view of what and where falls are happening in their community. Next slide, please. There's a second kind of project that you can do when you're looking at multi-sector data. And that kind of project is characterized by something that we've recently been calling care coordination, but the newest buzzword for this is whole person care. And the idea around care coordination or whole person care is that traditionally, health has been determined by what happens inside of the doctor's office. But that great slide from Justin earlier about the model for rankings and roadmaps, for those of you who aren't super familiar with it, that really says, hey, about 20% or so of health happens there in the hospital or doctor's setting. The rest of it is outside in the community, determined by social and environmental factors. So in this case, even if we are working with people in a health setting, you also want to integrate other kinds of information. So for example, in Dallas, Texas, the Parkland Center for Clinical Innovation at the Parkland Hospital Health and Hospital System is partnering with the North Texas Food Bank and a bunch of local food pantries to share information about individual people so that their care is better coordinated and their health and social outcomes improve. So that's an example of the kind of work that can happen when you bring information from different sectors to individual health outcomes. Next slide, please. So a lot of us are working in and starting to talk about the social determinants of health. We think of that really in terms of the sectors that represent it. And so obviously health care is represented by hospitals and doctor's office and health systems. And then, oh, excuse me. We are interested in a wider sense of what makes people healthy. And so we're concerned with housing and education and public safety, health, behavioral health, social services, and economic development. There's a lot of sectors too that aren't included here, including things like community safety, like transportation. Really, anything that has an impact on individual and community well-being is a sector that we're concerned about in terms of our multi-sector projects. Next slide, please. And in the same way that we are thinking about more than just healthcare data, we're thinking about all different kinds of data. So yeah, we've got service data that comes with the medical system, but we also have administrative data, like who pays for it. We've got geographic data. We've got personal demographic data, the things that describe who we are. But of course, with a lot of these exciting technologies, there's lots of individual and community generated data that's coming out of it. For those of you who are interested in evaluations, we've got performance and outcome data. And of course, from the public sector especially, we have surveillance data. Really, we are still gathering the sense for what kind of data can be combined with data that we've already got. But really, the big picture here is that we recognize that the more and better and diverse kinds of data that we can collect, the better we're able to understand and act in our communities. Next slide, please. So real quickly, this work is happening all over the country. Some of you are probably involved in it. We have created, for the purpose of trying to share lessons and connect people in this work, we've created All-In Data for Community Health. And All-In really is driven by the three missions, by the three goals that you see on this screen. And that's really, we want to be a part of a big movement where everybody understands what the social determinants of health are and why they have such an impact on health equity. We also are, by virtue of our close association with local communities, developing an evidence base for what works and what doesn't. And then finally, we're trying to build a network that recognizes that the best place to get information about your community and how to make it work is to talk to folks in other communities who've had similar experiences. Next slide. So there's a bunch of us who are working on this. You'll see our organization out at Cross Sectors for Health, but we've also got folks from Academy Health, the Build Health Challenge, the Colorado Health Foundation, the Public Health National Center for Innovations, New Jersey Health Initiatives, CASHI out in California, and then a lot of really important national relationships as we have with county health rankings and roadmaps. Next slide, please. This is kind of where we're operating right now. We are, through our partner organizations, involved in about 100 communities. Now, not all of them are working really specifically on data. Some of them are still in the stage of developing multi-sector collaborations. But it's our sense that over time, once you get the collaboration piece down and really start to develop multi-sector relationships, at some point, somebody says, wow, we need more data in order to understand or act in our community. And when you get to that point, that's where All-In and our partners and our communities are more likely to be helpful to you. So that's a really quick introduction to All-In. The most important thing about All-In is the communities within it. So I'd like to introduce Elise Citrini from LAF in Chicago, and she's going to give you your introduction to one of the All-In communities. Elise?
Thank you so much, Peter. So again, my name is Elise Citrini. I'm an attorney. I'm not a health professional. I work at an organization called LAF, formerly Legal Assistance Foundation. I work on a partnership called Health Forward, Salud Adelante, that was initially funded by the Build Health Challenge during a planning and implementation year. We're currently in our 3rd year, and we're being funded by the health system partner, which is Cook County Health and Hospital System. This project allows LAS, Cook County, and Chicago Department of Public Health to partner in this innovative cross-sector relationship, and we're focusing on some of Chicago's most health-challenged neighborhoods. We've developed this plan for addressing social determinants that have really the greatest negative effect on those residents' well-being. We used our providers' systems, aggregated individual data, as well as data from the Department of Public Health to track health trends, and so that we can look at where it makes sense to intervene. So this partnership, Health Forward, leverages this really, integrated system for providing legal service experts to within that healthcare model, and we share this mutual vision for impact at the community level. Parts of this partnership are upstream, and the design enables us to create a robust and coordinated response. All these 3 entities have long-standing good relationships over long periods of time, and our commitment to integrating this work is fairly new. And that's why these aligned goals, methodology, and the use of data is really very exciting. Next slide, please. So, how did we do this? We created a medical legal partnership between CCHHS, LAF, and CDPH to address health-harming legal needs. And our goal is to reduce the negative effects of social determinants on low-income residents of Cook County by sharing data, individual data, with non-healthcare providers, namely lawyers, in order to affect health outcomes. When a legal intervention is successful with a health-harming legal need, this should improve medical outcomes for patients and potentially yield reductions in healthcare costs for medical providers. There's also an evaluation component to the project, and we are asking the health system to document health benefits, reduction in healthcare costs, et cetera, after the legal intervention takes place. Additionally, we use community engagement to build a community-directed program and enable our residents to really tell us and really drive our interventions to let us know what the community's needs are in order to be responsive and address those, and then to bring that feedback from the community back into those 3 systems. Next slide, please. So again, the way we used our data to create this MLP was we used publicly available data from CDPH, which is called Chicago Health Atlas, as well as data from Cook County Health and Hospital Systems Business Intelligence to determine, and community engagement in the different focus areas of the city to figure out where the priority neighborhoods for this medical legal partnership should be, as well as what medical legal issues we should focus on to get the effect we were looking at. So yeah, we reviewed demographic, public health, aggregated patient data, and we looked for the areas of overlap with, where are there targeted areas under the city's Healthy Chicago 2.0, where were those targeted neighborhoods that they were looking at, where were areas where Cook County Health and Hospital Systems patient resides in kind of large numbers, where are there areas where there's strong ties within the community and LAF that already exist, where does the hospital system already have a physical presence, and then where are areas that have underutilized community assets as well as strong grassroots community organizations. And then again, areas where there's a high percentage of previously uninsured individuals or high population of immigrants is another area where we were looking at when we were deciding. So the 2 neighborhoods that we chose were basically represent the conversion of each of those criteria. So Back of the Yards and Garfield Park communities are really emblematic of Chicago. They are rich and diverse with strong community bonds, but both neighborhoods struggle with deep poverty, significant barriers to overall community good health. Almost every measured health outcome in each of these 2 neighborhoods is worse when you compare it to the city overall. Just looking at the graphic, like health disparity in terms of life expectancy, you can see it's a train ride away. The East Garfield Park is the area that says it's 72 years compared to the Loop Gold Coast, and the back of the yards community is adjacent to the Gage Park community, which says 79. And then in East Garfield, or rather, I'm sorry, in back of the yard, limited English proficiency is also a barrier if culturally competent healthcare providers are in short supply and the residents are with limited health literacy. Even in their native language, it makes it difficult for them to be active participants in healthcare. So almost every measure of health outcomes, like I said, is worse than in Chicago overall. Next slide, please. So then the other place where we used data was to figure out what were the legal issues that we needed to target. So so we used, again, the Healthy Chicago 2.0, which is the Public Health Department strategic plan, and Impact 2020 is the health system's strategic plan. And then the mnemonic iHelp stands for, it's a mnemonic that's used in medical legal partnership, and it stands for income, housing, employment, education, or personal family stability. And those are kind of the legal areas of focus that organizations like mine can really look at. And so then where we found areas of overlap between potential legal intervention as well as with the anticipated outcome of that legal intervention, and where those areas kind of supported the goals from both Healthy Chicago 2.0 and Impact 2020, that was kind of the sweet spot where we said this will make where we do these interventions, it'll have the greatest impact. Next slide, please. So then we created this service model, and the medical partner provider that we work with are the care coordinators at CCHHS. So those care coordinators are our primary point of contact. When they are working with a patient, they spot an unmet legal need. They make a referral to our attorney, who is part-time on staff, like on site there, but also is working on site at our organization, at our office. With patient permission, they make that referral. We do a screen, and then we go back to the provider and close the loop about what happened, what the intervention was, and if it was successful. Next slide, please. So as part of that back and forth process, we conduct trainings to those care coordinators so that they can spot those health harming legal needs. And we create tools like this one to help them identify, if green means go, blue means, kind of pause and maybe do a consult, and red means, this isn't something that we're going to handle, and so we're going to give you the tools to upstream that and get that patient that information right away. Next slide, please. So early on in the project, we needed to course correct a little bit because we weren't getting the numbers of referrals from the priority neighborhoods that we had anticipated. And so, with continued feedback and training with our care coordinators, we decided to accept referrals from patients receiving care coordination services all around Cook County. We continue to prioritize folks coming from the 2 priority neighborhoods in terms of those cases get, kind of a second or third look to see whether or not we can take that case for extended representation. But then additionally, we've kind of reprioritized our process based on legal issue, as well as an assessment about whether or not that individual patient had the ability to engage with other systems involved. So for example, patients with multiple long-term hospitalizations, patients who are homeless, patients who have co-diagnosis of substance abuse disorder, mental and behavioral health challenges, those are the folks that we prioritize. Next slide, please. And then finally, in order to stay focused and connected with our priority communities, we rely heavily on our community engagement efforts. We conduct community legal education events and surveys and focus groups to determine what tools or what's needed and what's going to be useful in those communities. We've created tools in both English and Spanish on health literacy, on land use. For example, that was a big thing that kept coming up multiple times. If I want to be able to use this vacant lot and turn it to something positive, so we created tools for that. We've conducted community sketch mapping events with the Department of Public Health, and then the legal issues that we did our education events on were really the issues that were surfaced by those community members. And this was very important to us to be able to be responsive to the actual needs on the ground of these communities. So some of those specific topics were related to violence, immigration questions, as well as reentry, challenges on reentry from the justice system, and substance abuse. So this provides a feedback loop on what is needed in the community and how we can be responsive and flexible to address those needs with all of our multi-stakeholder partners. Okay, so another community that is doing really great work in this space are the folks in Trenton, New Jersey. And so now I'm going to hand the presentation over to Martha Davidson at Trenton Health Team.
Thank you, Elise, and really enjoyed hearing about the great work you're doing. Before I begin talking about what we're doing, I just want to acknowledge that we have benefited from coaching from the folks at the County Health Rankings and Roadmaps and appreciate that greatly. And also were invited to the All-In National Convening last spring, which was a great way for us to connect with other communities and organizations doing this kind of work. And it really has informed our efforts since then. So thanks to both hosting organizations. It's a privilege to be here and present. As far as Trenton Health Team goes, we grew out of a crisis. One of our acute care hospitals announced plans to move to the suburbs, and this generated some deep concern both within the city of Trenton and the State Department of Health. So then Mayor Palmer commissioned a study to assess what are the needs of the community, what is the impact potentially of this move, and what are some potential mitigations. And one of the recommendations, you see here a number of recommendations, creating an integrated healthcare structure, addressing specialty care, consumer engagement strategies, health database and information system, expanding primary care access, improving public health indicators, all good. But one of the really important recommendations was that our healthcare system providers needed to come together and work collaboratively rather than always competing. So the four founding organizations were the two hospitals, St. Francis Medical Center and Capital Health, our federally qualified health center, Henry J. Austin, and the City of Trenton Department of Health and Human Services. The groups began meeting with a little duress at first. The state used some carrots and sticks to keep the people coming together. And over time, they found this to be really helpful. And so in 2010, this group submitted an application to create a new nonprofit organization called the Trenton Health Team. And that was approved in 2013, but retroactive to 2010. So that's how we started. And originally, the focus was very clinical. How do we reduce avoidable ER use from some of our frequent and really complex patients? And lo and behold, of course, a lot of these patients are dealing with not so much medical, but social issues. Next slide, please. And if you look at the Trenton community, we have a very similar profile to many other urban centers. It's a majority minority community with high levels of poverty, and of course, violence is an issue, and chronic disease prevalence way beyond the national rates. And We also have one of these life expectancy maps that shows a 14-year differential if you go from downtown Trenton just up one train stop to the suburban community of Princeton Junction. So 10 miles, 14 years. Next slide, please. One of the first projects that Trenton Health Team undertook as a newly created entity was a unified community health needs assessment. And this was done through a grant from the Robert Wood Johnson Foundation's New Jersey Health Initiatives, led by our partner, St. Francis Medical Center. And to do this assessment, a community advisory board was created, and the partners came together and shared their data. And then we added to that forums and personal interviews to really get the voice of the community. A data analysis was done, and then based on feedback from community residents, priorities emerged. Next slide, please. So the health needs assessment led to a health improvement plan, which was adopted in 2014 based on the priorities that were developed through the data analysis, which was shared across social service agencies, behavioral providers, the faith community, and the healthcare system, and area colleges and universities. Our community advisory board has now grown to representatives from more than 60 agencies, and based on the infrastructure, this collaborative structure that we've developed, we were able to secure funding from Trinity Health for their Transforming Communities initiative. We received a grant, well, the city and Rutgers University received a Plan for Health grant to develop health and food systems element for the city's master plan. And one of our community advisory board working groups worked closely in the Plan for Health to create that health and food systems element. It also led to the Build Health Challenge. And as I said, we went to the All-In Conference last April and met Cohort 1 representatives. And that was really helpful to us in developing a strong proposal for our Build Health Challenge concept. Next slide, please. As a result, this multi-sector stakeholders way of doing business has become just how we do it in Trenton. For example, one of the things we're working on right now, we have a strong partnership with the faith community, and we've been doing a program called Faith and Prevention through a grant from the State Department of Health, where we go in and we train lay leaders to deliver a curriculum, evidence-based, faithful families, eating smart, moving more, trying to encourage members to adopt healthier lifestyles. And now we're working on training health liaisons within some of those churches to provide support to congregants as they come out of the hospital. And we're doing this by creating a registry in our health information exchange so that the liaison at the church is immediately notified when one of the congregants who has signed up to participate is coming out of the hospital and may need some support, and we'll train them on how to do that. Next slide, please. As I mentioned, our Build Health Challenge is really a great example of bringing all these various efforts and partners together and focusing in on a target geography. Our goal is to create this safe and healthy corridor, which starts at our offices on the left-hand side and the Henry J. Austin Health Center, and Isles Inc., which is a great nonprofit here in Trenton that does work around community revitalization, including urban gardening, healthy homes, and a lot of work in the schools. And then moving up the corridor to Capitol Health Regional Medical Center. It also allows us to bring in some of our Trinity Health funding, which has a focus on healthy nutrition, physical activity, complete streets. So we're bringing all of these activities and programs together in this geography to see if we can really move the needle on health outcomes. Next slide, please. So as part of this Build Health work, our partner ISLES has done a block-by-block survey of the vacant buildings so that we can identify particular locations where we can go in and begin to make some transformative change. And you can see here what a building being abandoned can look like in a matter of just a few short years. So within the target community, you can see that we've had changes in both directions. Next slide, please. Where the last one went from pretty good to pretty bad, here's one that was vacant and now is occupied and has been significantly improved. Next slide, please. Then what ISLES has done is take this aggregate data and do this hotspotting map to show where are the concentrations of vacant properties and abandoned lots. And what we are going to do next slide, please. Next slide, please. There we go. Is use our health information exchange, which can do some great queries around specific geographies, diagnoses, and healthcare utilization. It has Medicaid claims data. So this is just, we also have a grant from the Merck Foundation developing a collaborative for diabetes care across the city. It's called CCDC, Capital City Diabetes Collaborative. And we've developed reports that help us to target the individuals who are going to need this care, stratify them into different levels of care that they might need. So our plan is to use these tools to overlay health data with the hotspotting that ISLES has done so that we could then determine what would be the right intervention and where it should be deployed. Next slide, please. So we'll take our health data, as I said, and overlay it with the geomapped housing information, and then identify and implement targeted interventions based on what we find. We also have a couple of other similar projects that are either pending or in the process of being proposed to work, for example, with the schools, taking their chronic absenteeism data and overlaying our health data, especially to see if there are patterns of, for example, asthma being an underlying issue for a child missing too much school. And then we will again look to ISLES to go in and do a healthy homes intervention to hopefully mitigate the triggers and help the, and in some cases it's more than one child, do participate in school more fully and hopefully have greater success on the basis of that. And we're also working with them on a similar approach around the issue of lead, which is a big problem with our old housing stock, substandard. You know, a lot of these properties are a hazard to the families who live there. So it's ambitious, it's exciting, and this is just a little sample of the things that we're doing. And I'll hand it back now, I think, to Peter.
Hey,
Thanks,
Peter.
Martha.
Hey, Peter, this is Justin. I was going to jump in just for a second and respond to an inquiry that was coming up. This is the first time we've had so many great organizations and communities on one webinar, and I know that the attendees feel like they're getting, you know, fire hosed a bit with so many good resources and things. So we're going to capture all the chats and we're going to try and pull together kind of a resource list of everything that's been talked about and shared about throughout the webinar, along with providing the slides after the fact, so just so folks feel a little more at ease with that. Thanks for letting me jump in, Peter. Go ahead.
No, that's great, Justin. It's kind of our way to celebrate the work that's happening locally. It's really what defines All In generally. I want to give us time to get to a couple of questions, so let me just skip over our slide about our activities. If you've been a part of a learning collaboration, we do all the stuff that you would normally expect. A lot of you in the chat and on the questions are asking about joining or participating in All In. I would recommend two different things. If you're really interested in just getting started, you can sign up at allin.healthdoers.org, and at there, you can continue this conversation, access our resources, look at events, and most importantly, start to understand who else is working in this work. We got a great question from Sarah Green, who asked, is there some kind of catalog? So I want to point you to a list of active projects right now at our site at allindata.org. If you click on the map of our communities, below it is a short description of about 60 projects. You can start there, but we are working on developing a catalog. In the meantime, if you go to allin.healthdoers.org, you can join in, and there's more information about some of the projects there. The other thing that happens when you join the All In platform is that you have access to our staff in office hours, and we're able to follow up with you when you give us individual questions. We're desperate to share and get to know you and connect you with other folks we know. But one of the folks that we're proud to know are the folks at County Health Rankings and Roadmaps. So Justin, back to you.
Great, Peter, thanks. So I'm going to move us into the Q&A. We have about 5 minutes or a little more to address some questions. I want to acknowledge that a lot of great questions came in pre-registration or ahead of time. So I have a few of those queued up, and we'll dive into those, and then we'll move into some of the excellent live questions that came in the last hour too. So. First question I have is, what is some advice for sharing data with non-clinical entities? And I think maybe Elise might want to jump on this since she works in a non-clinical setting.
Sure. So like I mentioned at the beginning, like I am an attorney. I work in a law office, so very little experience and history working in a health system. And so the data piece, it was something that was very new for us in a lot of ways. And so, and that was also kind of one of the big challenges we had at the beginning of our relationship with Cook County Health and Hospital Systems, because when they are sharing information with us, we had to make sure, everyone had to make sure that the protections for the health information were there and in place prior to any information exchange. And that process really took a lot longer than anyone anticipated. And it's possible because we are an agency of lawyers, so we wanted to make sure that the legal side was very clear, and that the risk was managed on our end as well as on theirs. So like the main recommendation I would have is to start that process of how are we going to, like the actual mechanisms for how we share this data, what requirements are we going to have of our partner? Is that partner going to be a business associate, and do we need a business associates agreement? Is that partner not going to be a business associate, and what do those things mean? And kind of like calibrating the level of risk that each entity is willing to take in terms of sharing that data. Definitely not meant to scare anyone off, but just meant to say, these are things that we don't necessarily think about, like just the actual mechanisms for sharing that information, and to start it early.
Thanks, Lisa. I think, and you just hit on, that patience is important too. It could take a long time. And Martha shared, if you looked at the timelines and what it took to develop some of their work, she was looking at, 3 to 4 years of development, right? So it's not going to be a quick quick fix, but definitely worth the time in investing. Thanks for sharing. I think I want to skip to another question on, and I think we queued this one up for Peter, how to get multiple sectors to really agree on common metrics and identifying the best IT solutions for sharing data.
I love this question because it gives me the opportunity to dispel the myth that the question is, how can we get other people to help us to achieve our goals? Because I really want to make the point that these multi-sector collaborations and multi-sector data projects really work best when folks come around a common table and can find those points of mutual interest. The places where what you're trying to do and what I'm trying to do are best done together. And so rather than inviting you to my table or necessarily going to a neutral table, let's gather around one table and talk honestly about what we care about, how we talk about this work, what we have to offer and what we need. This kind of transparent communication is absolutely foundational for the work to start. And regarding the question about sort of what technology solution, one of the vexing things about these multi-sector community projects is that they tend to be hyper-local. And so even though data nerds like me and some of the folks on this call are excited about wanting to get all the data, in reality, we have to be really clear about what it is that we're trying to do, the solution we're trying to get, the problem we're trying to solve, and focus in on probably the minimal set of data that's required to do that. If you're clear about what you're trying to do and what the data is, that will sometimes lead you to the technological solution. And of course, the best way to understand the options for that are to talk to other folks who've been doing the same work.
Thank you, Peter. And I think the tool I shared earlier kind of spoke to the first question too, about really thinking about that common goal and finding your ways you differentiate and integrate best with who's at the table. There's been so many excellent questions. I just want to thank everyone. There's so much coming in live, and I only went through 2 of 10 we had prepped ahead of time. So we just are out of time. And but I think it really speaks to the need for a discussion group or a follow-up conversation. And we are hosting one next Monday, May 21st, at the same time. And this is really an opportunity for you guys to engage in the peer learning that we were talking about, to answer these questions. And we're going to kind of call some of these themes that came up today and bring them to the discussion group next Monday. And it's an interactive way for you guys to connect with other communities and continue this shared learning process. So I invite everyone to register for that as well. Peter, do you want to hit on a couple of your staying connected opportunities here?
Thanks. I just encourage folks to get basic information about our work at allindata.org. I've already talked about joining the All-In community at allin.healthdoers.org. When in doubt, shoot us an email at info@allindata.org and we'll put you on the mailing list. We've got a pretty sweet monthly newsletter. It's a good way for you to dip your toes into this world. Again, I just want to thank everybody for participating. It's a joy for us to try to tell our stories.
Thanks, Peter. I'll contend that our e-newsletter is equally sweet, and you can also follow us at CHR Rankings and on Facebook as well to stay connected with county health rankings and roadmaps. And finally, just a big shout out and thank you to All In and Dash and the great folks over there, and most importantly to our community guests in Trenton and in Chicago. Thanks, Elisa and Martha, for being part of this webinar and sharing such great examples of this work. We look forward to connecting with everyone soon on a upcoming webinar, and have a wonderful afternoon.
Thank you.